Hello, my name is Tara Denner, and I'm an outpatient psychiatric nurse practitioner. Today I'm going to walk you through how I would address a crisis situation with a patient I've been treating for several months now. The patient is a 45-year-old male with a history of major depressive disorder and a past pornography addiction that has previously caused marital strain. For the 5 past years, his depression has been well managed with Celexa 20 milligrams daily. His marriage has stabilized. Today, however, he presents in acute emotional distress after discovering that his wife has been cheating on him for the past 2 years and has left with their children. His clinical presentation. When he entered my office, he was visibly tearful, upset, overwhelmed. He reported that his wife left a note detailing her infidelity and has their children with them. The man he has been involved with, they are living together now. He stated he feels stupid, hopeless, and questions the point of the self-improvement that he has done. Was it even worth it? He states. He reports missing work repeatedly, fears losing his job. He has not spoken to his children in a month, and they are his primary protective factor. When I ask him about suicidal ideations, he reports he has been suicidal since she left. He's been drinking at least a 6-pack nightly, and he admits to having a plan of shooting himself. When asked what keeps him from acting on these plans, he says, "My children, but I don't have them with me, which makes this hard." The crisis assessment. At this point, I conduct structural suicide risk assessment. According to the APA practice guidelines, active suicidal ideation with a plan, access to means, recent psychological stressors, and substance abuse elevate the risk. He meets an intermittent risk due to active suicidal thoughts, an active plan involving a firearm. He has access to a firearm. Alcohol use, which increases impulsivity. Severe psychosis with stress. Deteriorating functioning and weakening protective factors. He is unable to reliably contract for safety, and his judgment is impaired. Immediate interventions. My next steps is to ensure he does not leave the office. I explain calmly and compassionately that due to the severity of his suicidal thoughts and his present of a plan, he requires a higher level care. Your pain is real and your reactions make sense given what you have been through. But right now, your safety is my priority, and we need to keep you safe today. I initiate an emergency psychologic hospitalization, a B52, which is an involuntary hold. This is consistent with evidence-based crisis management guideline, which recommended hospitalization when a patient has intent, plan, and access to a lethal means. I then address the firearm access. I ask him where his gun is and if he's accessible to it, whether a trusted person can secure this immediately. If not, law enforcement may need to intervene to this safety risk. We can also address an RPO if necessary. I also address his alcohol use. Drinking a 6-pack nightly increases impulsivity and reduces inhibitions, making him more likely to act on a suicidal thought. Hospitalization will allow safe detox monitoring as well. Communication approach. Through the conversation, I use supportive, non-judgmental language. I validate his grief, betrayal, and loss. I avoid minimizing his feelings and offering false reassurance. I emphasize that hospitalization is not a punishment, but a step towards stabilizing him so that he can reconnect with his children and gain control of his life. Documents and legal steps. I document his suicidal ideation plan, access to firearms, protective factors, substance abuse, and the rationale for hospitalization. I follow state laws for involuntary commitment if necessary. In the end, by summarizing the crisis plan, reinforcing that he will not face this alone, I tell him that once he is stabilized, we will work together on his grief support, medication assessment, and reconnecting him with his children. Thank you, and have a great day.